Hi guys, David here. So we know that the patient is here, and so we can start beginning to prep the room for the patient to come in here. So what I've done here is I have the monitor here ready for the radiologist to look at while he does his fluoro, and I've parked the tube here as well. And normally we would tape down this padding here on the table as well because he will be going upright and we don't want him to be sliding off anywhere. And I've also put the curtains on here as well for the doctor. It'll help bring the fluoro tube down while he's doing his procedure. So now we have all the supplies here. So we have our lube here, just to be sure to lube the tip of that. And we have our cuff inflator here that I'm going to attach to this little vessel here. And now I'm going to make sure that this isn't a defective kit or anything by pumping it. We're going to give it one good pump and then clamp it right off. And we have these hemostats here that are also the extra safety or precautious hemostats to clamp off the tube here and make sure that we're not going to let any air out of the balloon there. And then we're going to go ahead and attach the bulb here that's going to pump the air into the patient for the double contrast study. And so I'm going to make sure it's coming out of the fenestrated holes here, and that looks like it's all working really well. Then we have our barium mixture here is already pre-mixed. It looks like it has a 105% weight to volume ratio, and we're going to fill up the bag to about 1800, which is right below the 2000 mark there. And we have our stand here where we're going to hang the bag, and it's going to be about 18 to 24 inches depending on where the doctor wants you to put it, and no more than 24 inches. My name is David Acosta, and can you tell me your first and last name, please?
Dan Rohrback.
And your date of birth?
5151.
Alright, looks like you're the right patient. Okay, so what we're going to be doing today is that we're going to be doing the BE study, the barium enema study, and it's a study of your colon. And in order to do that, we're going to have to insert this enema tip through your rectum, and this is the enema tip we will be inserting through the rectum. As you can see, it's about the size of my finger, so it's not too, it's not too big, and it's going to go as far as you see the bottom of that plastic there. It's a latex-free plastic. And once we insert this in there, the radiologist is going to be administering barium. Now, barium is a substance that's too thick for our X-ray machine to see through, but what we use it for is to line the walls of your large intestine, your colon. And we're going to be pumping enough barium in there to fill your whole large intestine. And once we do that, we're going to drain it back, and that's going to line the mucosal lining in your intestine. And after that, we're going to add air, and the air is actually going to be what's going to allow us to see the lining of your intestines a lot better and see, all the little details, any small lesions or anything like that. Once we finish doing this, we're going to kind of roll you around a little bit, probably the whole 360 degrees, and just kind of help mix up some of that barium in there and coat the walls of your intestine properly. And we're going to do this, there's no race here or anything. We're going to do this at your pace, so you let us know if you start feeling too uncomfortable to handle, and we'll slow the whole procedure down. Does that sound good?
Well, yes.
Alright. Okay, so I'm just going to be doing our AP Scout right now, so this is with no barium or anything just yet. And make sure our tube is detented transversely. And I'm looking to line this up, and our central ray is going to be at the top of his crest, the iliac crest. So I'm going to feel for his as-is and walk my fingers all the way up to the top of his crest, which is about right there. That looks about right. Open up the collimator. Make sure that this is lined up. We have a 14 by 17 in here. the patient has their hands down to their side. I'll put my marker. I probably put my right marker on the right bottom corner of the cassette, and then we're going to be coming right over here to the reader, and I would set my technique. I'd probably shoot this at 80 kV and 80 mass if I was going to do it manually. I'll instruct the patient to take a breath in and then blow it all out and hold that, and I would take the picture. So I'm going to have you turn onto your left side for me, and we're going to have you bend your legs up, so kind of, yeah, there we go, kind of curl up a little bit. We call this the Sims position. And now I'm going to be inserting the enema tip here, so I'll make sure to lube it up, and we're going to be starting off with inserting it, and I'm going to be going in the direction of his belly, as if I was going towards his belly. I'm going to go in about 3.5 to 4 inches, no more than 4 inches, and as I'm going in, I'm going to kind of corkscrew it in or kind of turn it as it goes in, because that'll help just kind of get it in there a little bit better. Eventually it'll feel like it'll just kind of fall into place there, and I'll know that I'm in, and we'll be sure to blow up the balloon, and then just clamp it off, use our hemostats for the safety clamp, and the doctor will begin administering the barium and whatnot. So to begin our A overhead projections, I'm going to make sure I shield the patient properly, so I'm going to put the shield there. And then we would begin doing our A overhead projections, and we would just move the shield accordingly throughout each image. But for the purpose of this trigger, I'm not going to be actually showing the shield throughout all the images, but just so you know, we would be shielding throughout the A overhead. A axial, or also known as the sigmoid shot. We're going to put about a 30 to 40 degree caudal angle on it. Usually a 30, and it's going to be lined up about the level of the as is, which is about right there. Make sure that our fuck is lined up. Inserting a 14 by 17 and putting my left marker in the left hand bottom corner there. Setting the technique at about 103 and mass at about 25 or so. From here, I'm going to take the cassette out, run it through the processor, and I'm going to have the patient go into the RAO position, recombinant position, and I'll make sure our bucky and everything's lined up with the tube. Use a 14 by 17 with this shot, and I'll put my left marker there on the bottom left hand corner. I'm going to line up the central ray with his iliac crest, which is about right there, and make sure my bucky's lined up. And I'm going to set my technique to about 103 at 10, which is going to be the baseline. Most facilities use the AEC for all these shots, but if we were going to do it manually, we would set it to about 103 kV with 10 mass. That's a good baseline there, but it all depends on the body habitus of the patient, of course. So the next one I would do from this position is I would have the patient, he's going to be flexing his left knee and turning over to his right side a little bit. Right cheek is going to be laying down on the pillow, and he's going to be resting most of his weight on his left forearm. So let's go ahead and roll you up towards your right. Yeah, you'll tuck the right arm in, and that looks like he's in a pretty good RAO position there. I'm going to go ahead and line up our tube here. Going to be at the iliac crest and about 1 to 2 inches lateral from the midline of his body, of his mid-sagittal plane. So that's about right there. And once again, using a 14 by 17 set for this and shooting it at a 103 kV and 10 mass, same technique. And from here we'd move on to the LAO position, which is we're gonna have you get back on your belly and then tuck your right or your left arm in now and look to your right, and then we'll have you flex your right knee and rest most of your weight on your right forearm there. Again, centering at the iliac crest and 1 to 2 inches lateral to the midline of his body. Another 14 by 17 we would place, same technique as before. Since we have him in this position here close to the lateral artery, we're going to go ahead and shoot lateral. So we'll have you just lay on your left side. So you're just going to roll up onto your left side there. And then we're going to use a 10 by 12 for this, but we can use a 14 by 17. Depends what the doctor wants to see. If he wants to just see the rectum of the sigmoid, you usually can get it on a 10 by 12 lengthwise. And we'd go ahead and insert that in there. We'd be lining this up about 1 or 2 inches below the level of the as is, about right there. And then we'd be shooting it at the same technique again, 103 kV, 10 mass. And from this position, we'd go ahead and just start doing our left lateral decubitus since he's already on his left hand side. We'd be moving this over here. So again, centering at the iliac crest. And we would go ahead and shoot that at the same technique once again, 103 kV at 10 mass. From here, we would go ahead and do the left or the right lateral decubitus, and we just have him turn over onto his right side. So just turn around towards the board there, and we would center again at the iliac crest and shoot at the same technique. And we want to make sure that the patient is usually as close as the board as we can be. So if we can get him to come a little bit closer to the board, that'd be better to reduce. I'm doing the 8 overhead projections, and my post instructions to the patient would be to go back on your regular diet. Just make sure to drink plenty of fluids, water, juice, coffee, anything really. The barium enema is pretty thick and it tends to constipate you, so you want to filter that out. The first image we're looking at here is the AP Scout that we took, and you can't see any of the barium anything because it's not in there yet. You can see some gas here in the descending colon part of it, but everything else looks pretty clear. You can see some gas here in the sigmoid area. And so we'll go on to look at the next one. Which is our PA axial, and this basically helps visualize the rectosigmoid area a lot better. You have less superimposition than in the regular PA projection because of the angulation of the central ray. You can't always see the whole transverse colon and both flexures, but what's important here is seeing the sigmoid and the rectum here. Sigmoid and the rectum. So we have our PA projection here. We have the whole colon basically on site. The ascending colon here to the right hepatic flexure, going through the transverse colon into the left splenic flexure, and down the descending colon into the sigmoid colon, and then the rectum finally. We can see the spine is centered here. So what we're looking at here is LPO projection, which is equal to an RAO projection, and that is the one that I did as part of my overheads. In an RAO projection, the focus is on the right hepatic flexure, and as well as in the LPO, the focus is on the right hepatic flexure, which is right here. As you can see, you can still see the left splenic flexure as well here. You can see the ascending really well on this position projection as well as the descending here. And this projection here is an RPO projection, which is equal to the LAO projection that I did as part of my 8 overheads. We can see the focus here is on the left splenic flexure. You could also see the descending colon really well. This is our lateral projection here. As you can see, we have our sacrum right there. This is our rectum, and this is the sigmoid here. Going up into the descending colon. You can see the pubic symphysis here, and we know that there's no rotation because you don't see two femoral heads, so they are pretty good. They're pretty superimposed over each other. Our right lateral decubitus. As you can see, the air levels here on the lateral aspect of the descending colon and the medial aspect of the ascending colon, and those would be our points of focus here. And here's our left lateral decubitus. You can see the air here on the lateral side of the ascending colon, and then air here on the medial side of the descending colon, which would be the areas of focus. Whole colon from top of the splenic flexure to the sigmoid and rectum that are right down there. And that concludes our barium enema study.